although neither pembrolizumab or nivolumab are approved frontline for melanoma, the NCCN has said specifically that they should be used frontline. And when the NCCN says that, a lot of times the insurance companies will pay for it and doctors will start trying to do it. And so it complicates things even more. To me, everyone always talks about which drug first and what's the best choice and should it be combination therapy or monotherapy. To me, it's more about sequence and timing. But those are the harder questions to answer. Should you be giving this drug first followed by that drug? Or that drug followed by this drug? Should you only give this drug for 3 months and then switch to another one? Should you use biomarkers to decide when to switch? I mean, there's so many unanswered questions, but the bottom line and the great part for patients is that now there are drugs that are proven to be more and more effective for people who just 5 years ago had really no hope. From a targeted therapy perspective, we're looking at a new combination with vemurafenib and cobimetinib, so another MEK inhibitor that hopefully will be approved soon, because combination therapy for those patients seems to be much better than monotherapy of either agent alone. And I think we also want to have a better understanding of why most or almost all patients develop resistance to the BRAF or MEK inhibitors at some point, unfortunately fairly soon, and then how can we stretch that time? Because if everything relates to getting a great response over a finite amount of time, is there anything we can do, any drug, any dosing regimen that will extend that period of time? Because at the end of the day, as all the drugs that are approved now and all the great results, at the end of the day, at least half of the patients, or 40% of patients, are going to fail. So all these great drugs, sequence, combination, whatever, 40% of them at the end of the day are going to be looking for something else. And if we can give them more time until something else becomes relevant, or the term something else becomes relevant, it would be a great thing. Most people believe that in order to be treated with a BRAF or MEK inhibitor, you have to have the BRAF mutation. And once you have that mutation, the question becomes, which should I do first? And it comes down again to sequence and timing. Should I do a BRAF and MEK inhibitor first? And almost everyone is giving the targeted therapies in combination. Should I do that first? Should I do immunotherapy first? The advantage of the targeted therapies is they act quickly and they act very comprehensively in terms of really eliminating almost all the cancer in the majority of patients. So fast, effective action, but limited in time. The immunotherapy is less likely to cause a response, but if you get that response, it lasts a long time. Most people nowadays are choosing targeted therapy at the outset if the patients have 3 things sort of in combination. A lot of cancer, cancer that's growing fast, and cancer that's causing a lot of symptoms. Kind of or. This, that, or the other thing. And you can spot these patients when they walk in the door. First time you see them, you can say, oh my, this person's having pain from their cancer, there's tumor everywhere, they don't feel well, they can't get out of the wheelchair, they're on oxygen. It's very clear-cut in almost all cases who fits into that category, who needs the targeted therapy right up front. And then hopefully, I think for most of us, what we're thinking is, let's get them to a point where almost all the cancer is gone and then switch them to an immunotherapy. If we can do that, then hopefully we can get the benefit of the long-acting, long-lasting effects of the immunotherapy. And if we haven't yet developed resistance to the targeted therapy, in theory, if they fail the immunotherapy, we can go right back to targeted therapy and still get a good response. I think that in places that treat a lot of melanoma, the trend is definitely away from treating with targeted therapy until you fail. Because when you failed, you have 2 things. You may not have a good option, and secondly, the tumor may have mutated in some way that makes it harder to treat. One of the really interesting things about patients with BRAF mutated melanoma is the ongoing question as to whether or not there's a prognostic impact to being BRAF mutated. And most studies would suggest there is not. However, there's always been a suspicion that there is in certain subgroups, and also that if you are treated with a BRAF and MEK inhibitor and you develop resistance to that BRAF/MEK inhibitor, you may have changed the basic nature of the cancer such that the cancer is now more aggressive and harder to treat. So that's an unresolved question, and maybe that'll be at ASCO this year as to whether or not if you treat to progression, people do better or worse than if you treat to, let's say, a nice response and then switch to immunotherapy.